All right, we'll go ahead and get started. And on behalf of the Tiny Baby Collaborative, welcome to today's webinar, Establishing a Tiny Baby Program. My name is Noelle Young. I'm a neonatologist at Duke University in the US, and it's my pleasure to introduce our speakers and moderators for today's webinar. Our first talk will be presented by Dr. Jennifer Walsh. She's a neonatologist at the Royal Women's Hospital in Australia. Our second talk will be presented by Dr. Helen Healy. She's a neonatologist at Beth Israel Deaconess Medical Center in the US. Following their presentations, we'll have time for questions and discussion that will be led by our panel of expert moderators. Dr. Johan Agren is a neonatologist at the University of Uppsala in Sweden. Dr. Brady Thomas is a neonatologist at the University of Iowa in the US, and Dr. Thea Tagliaferro is a neonatologist at Cedars, Sinai, Guerin Children's in the US. Before we get started, just a couple of quick housekeeping points. This webinar is being recorded, and the recording will be posted to our website, tinybabycollaborative.org, within the next week or two. We welcome multidisciplinary attendance at these webinars, including families. If you have questions that come up during the webinar, please use the Q&A button in Zoom to post your questions, and the moderators will do their best to get to as many of them as we have time for. Thanks to all of you who attended the Tiny Baby Collaborative session at PAS last month in Boston. If you have feedback about the session, we'd love to hear it. You can get in touch with us using the contact link on our website, tinybabycollaborative.org. For those of you who are part of the Tiny Baby Collaborative and submit data to the mini registry, site reports are now available. If you'd like to take a look at your data or have questions, please get in touch with your site lead. So around half of our attendees today are neonatologists, but we're also happy to see that we have a strong representation of nurses, nurse practitioners, trainees, dietitians, and others from over 40 countries. We asked on the registration form whether your NICU has a tiny baby program, and over half of you responded that you do. We also asked about components of tiny baby care in your hospital. You can see that 28% responded that there's a dedicated physical space in the NICU for care of infants born less than 25 weeks gestation. 27% reported having a trained group of nurses dedicated to caring for these infants, 17% a dedicated team of physicians, and 13% have a consulting team for care of infants born less than 25 weeks. We also asked about whether any specialized training was required for caring for these infants. About half said no, but you can see that 27% reported that some additional specialized training is required of nurses, and 13% responded that additional training is required for physicians caring for these infants. All right, so that's all I have. I will turn it over to Dr. Jennifer Walsh to begin with our first presentation. Thank you.
Good morning. Today I'm going to talk about building a successful tiny baby program, and it sounds like I'm preaching to a lot of people who already have tiny baby programs, but I guess I might give some ideas about what worked for us when we've been evolving our tiny baby program over the last couple of years. It is. First of all, I have nothing to declare, and all the photos that I share in the presentation are with parent and survivor consent. The contents of my slide will include a bit about my background and the context for my interest in tiny babies, the numbers of babies that we've had at the Royal Women's Hospital in Melbourne since 2021, a little bit about the variations in outcomes and evidence for tiny baby programs, and then going on to important factors to consider when establishing your own tiny baby program. And finally, then the important part of learning from every baby. So I'm originally Irish, as you can probably tell from my accent. I moved to Melbourne, Victoria in 2008 to complete my neonatal training. And obviously I didn't go back. I work in Melbourne, which is in the state of Victoria. You can see in the green section down at the bottom of Australia. And in 2023, we had about 78,000 births. There are 4 NICUs. 3 of those are perinatal centres that will care for babies at 22 and 23 weeks. 2 surgical centres, one of which is also one of the perinatal centres. At the Women's Hospital, we have between 6,500 and 7,500 births per year. We have a 62-bed NICU, 12 HDU beds, and 24 NICU beds. And we care for approximately 120 extremely preterm infants every year. In late 2020, which became operational in 2021, Safer Care Victoria published an extreme prematurity guideline. Safer Care Victoria is an administrative office of the Department of Health that works with clinicians and consumers to develop better health services and provide better quality health care. They published a framework for approaching the care of babies within the zone of parental discretion. This schema basically gives you the outline of the main aspects of the guideline and the continuum of shared care decision making within the zone of parental discretion. Care at less than 22 weeks is not supported in Victoria at present. And between 22 and 23 plus 6 weeks, it's the zone of parental discretion where we will work with families to decide what the right thing to do for them. Care at 24 weeks is generally a given unless there are significant adverse risk factors. Since that guideline came out, there was a little bit of turmoil, a lot of misinterpretation, and a feeling that not all units were on the same page. Indeed, at the women's, we had several outborn babies at 22 and 23 weeks, some of whom even were born in their home environment and transferred into us. And then over the following year, we pursued a lot of discussion, a lot of collaboration. In our hospital, we had a lot of opportunity to have internal counselling discussions. We collaborated with our obstetric colleagues. There was a statewide collaborative group formed which shares experiences, outcomes, and quality improvement initiatives with each other. And there was a drive for unity of approach. Through the time, there's been a shift in attitudes and a belief that with hard work and collaboration at hospital, state, national, and international levels, that we can provide good quality care and give hope to families. I thought I would just share with you simply the numbers of babies that we've had since 2021 in the Royal Women's. So we're not an expert centre. We have very small numbers. In the 5-year epoch, we've had 12 babies who had care provided at 22 weeks, and 7 of those babies survived. And we've had 47 babies at 23 weeks, and 27 of those babies have survived. So it appears that we have a better survival rate at 22 weeks compared with 23 weeks, but that is likely more related to the context of counselling, the attitudes, and the fact that if a woman presents at 23 weeks without having had counselling or steroids, we will automatically provide care. Barbara Stoll's group has shown that there's huge variations in survival amongst NICHD centres during the period of 2003 to 2007, from less than 5% to greater than 50% at 23 weeks and 20 to 100% at 24 weeks. And in those groups, there was no detectable differences in indicators of acuity or illness severity. And several studies have shown that centres that uniformly and aggressively treat mothers in labour and resuscitate extremely preterm infants have better survival rates than those who took a more case-by-case approach. Matt Rasavi's group has also shown that a proactive approach in treating all comers consistent with parents' wishes have higher survival rates and higher rates of survivors without major disability than units that are more selective in offering intensive care. Is there any evidence for small baby programs? In the early days, Nankervis showed that in 2010, a study with babies less than 27 weeks, this was a pre-post implementation of a small baby program, showed that there were shorter lengths of stay, higher survival without BPD, and higher survival without severe IVH. And Mindy Morris showed that chronic lung disease rates were reduced in the post implementation period. They also showed a reduction in hospital-acquired infection and, very interestingly, a reduced resource utilization with laboratory tests and radiographs reduced in the 2-year comparison periods. What we do know is that there's large institutional variability in survival, and this is often attributed to differences in management. And the centres of excellence achieve consistently high survival without severe morbidity. They're often sought for guidance, and often their clinical practices differ dramatically. So it's important to choose what's right for you and your institution, ensuring consistency of practice through collaboration and guideline implementation. What should we consider when building a tiny baby program? Having champions for quality of care within your NICU is critically important. Form a formal leadership team that includes neonatology, obstetrics, maternal fetal medicine specialists, and nursing staff. And ensure that your leadership will provide you time and resources to make it a success. This picture shows a little baby who was one of a set of twins, Thomas, born in 2001. His parents back in 2001 advocated very, very strongly for care provision for their twins at 22 weeks. And he had an excellent outcome. And it's been 20 years, it was 20 years until we began to collaborate with families and provide care for babies at 22 weeks after that. The Tiny Baby leadership team will be responsible for reviewing current practice and identifying areas for practice change. You need to consider whether a specific tiny baby care team, whether that be medical and or nursing, is right for you and your NICU. In our NICU, we don't have a specific care team, but we have developed a nursing allocation guide which ensures that the babies are cared for by the most senior nurses on shift at the time. We know that it needs to be a multidisciplinary team. It needs to include physicians, nurses, advanced nursing care practitioners, respiratory therapists in the US, but not in Australia, allied health specialists, social workers. You may want to include members of the hospital ethics team, and of course, parent and family representation is key. This picture shows a group of clinicians at the Royal Medical Hospital, medical, midwifery, and nursing staff who are awaiting the birth of extremely preterm twins during the very restrictive COVID era. I'm at the front with another hat on, being an EPIC trainer during EPIC implementation at the same time. Whatever you do, you need to work with others doing the same thing. Some of the things that can build your knowledge within your unit are to invite speakers to talk about aspects of tiny baby care, attend these tiny baby webinars, participate in Centre of Excellence site visits. This picture shows a group of Australia and New Zealand neonatal network members on site visits to Japan in 2024, where we attended several units and learned about their tiny baby care. We were very warmly welcomed and learned a huge amount. Collaborate at all levels. Share any knowledge widely that you gain beyond, and we collaborate at state, national, and international level. And knowledge needs to be shared at forums, for example, your MFM, NICU Grand Rounds, medical ethics sessions. 2 weeks ago, we held a tiny baby perinatal mortality grand round and shared updated perinatal statistics, as well as discussing the care of a set of 22-week twins. This has been a really important initiative in Victoria. And a very initially driven by the Safer Care Victoria guideline, where we collaborate with all of the NICUs that care for babies at 22 and 23 weeks. It involves all of the units as well as the retrieval service, providing care for these women and babies if they're born. And it's important for us because it has driven a unity of approach and an improvement so that we're all trying to be on the same level, particularly when involving transfer of babies to the different centres. In the early stages of any programme, it's very important to collect baseline data. We collected an awful lot of baseline data and we continue to collect this data. And it's only when you look at your data and critique it that you can actually find areas for improvement. One of the areas that we found interesting to look at was antenatal steroids. And we really found that we could not necessarily change the incomplete steroids for women who had not attended the unit, but we looked for missed opportunities for steroids. So, for example, women who were sitting on the antenatal wards who had not had counselling or consideration for steroids who went on to birth. And we've really helped honed in with our obstetric colleagues on looking at missed opportunities for things like steroids within our NICU. Luckily in 2025, in the babies less than 26 weeks, we had no missed opportunities. It's important to build consensus within your unit, and that is a very difficult job. We needed to do that within the neonatal group, but also collaborating with our obstetric colleagues. And that involves quite difficult discussion and making some decision points for your NICU. What is the lower limit of care you're going to provide? Is there an upper limit for comfort measures? What are you going to do with regards to counselling, antenatal steroids, fetal monitoring, cesarean sections? And continuous discussion needs to occur as your consensus will shift and you will need to revise your counselling, your care provision, and what is right for your unit as you improve your statistics. And through it all, it's important that you ensure equitable care, including perinatal and counselling. There is a lot of overlap with current working groups that work in our NICU. And so it's really important that we outsource, we collaborate, and we regroup. So we have a lot of different subgroups that have established different protocols and brought them back to the tiny baby group. We've recently published our respiratory care for infants born less than 25 weeks gestation, which was led by a respiratory working group. And in the absence of any clear evidence, we know that standardizing practice can improve outcomes. And so we have standardized care for babies, particularly involving admission to NICU now on high frequency oscillatory ventilation with volume guarantee. Evaluate any new practices that you bring in and how they're embedding within the unit with continuous quality improvement. We have finally finished a tiny baby sodium delivery audit where we looked at sodium delivery for our tiniest babies in our NICU and hope to present that to the group in the next week or two. Through all of this, we've constantly showcased how what we have done, the audits that we have completed, and the work that we work on and that we continually evaluate. We recently showcased antenatal counselling practices during two periods and showed that we have had a significant improvement in adherence to joint counselling with neonatal and obstetric clinicians present when counselling women at 22 and 23 weeks. We've also had some really nice work done by one of our neonatal fellows, soon to return to Canada, looking at the hemodynamic transition of the tiniest of babies in our unit at 22 and 23 weeks. Programs need to develop protocols specific to the care of the tiny baby, and these will include all of these areas, but are not limited by these areas. So, prenatal obstetric interventions, delivery room and golden hour management, respiratory care, cardiovascular care, vascular access, fluid and electrolytes, skin, GI and nutrition, infection prevention and management, neuroprotection and neurodevelopment, and family-centered or family-integrated care, which is a practice that we've just brought into our NICU formally in the last 18 months. This is a really helpful schema, which was published by Laura Bernardini and Helen Healy, who will be speaking next. And I think I'm not going to go into any detail on it, but it's very helpful to help zone in thinking about the different aspects of care and the different areas that we need to think about when we're making a tiny baby program. And finally, just how important is it to learn from every baby? As I've already said, it's really important to collect data presented widely on processes and outcomes and engage with families to understand their needs. We have a consumer who sits on our tiny baby working group and has really changed some of the aspects of thinking that we have by being provocative about the emotional aspects of care. Consider being part of the Tiny Baby Collaborative multi-center inventory of neonatal perinatal interventions, or the mini study. We joined that late last year and are busy trying to enter data and babies. But formally review all of your processes. This may involve weekly occurring rounds if you've got lots of tiny babies in the NICU, case reviews, or regular joint reviews with the maternal fetal medicine specialists and obstetric team. And as I've previously said, look for missed opportunities and seek feedback. I'll take you through some of the different aspects of our tiny baby program that we feel is really, really helpful. This is a neonatal indicators dashboard within Epic that we've built specifically for our tiny baby key performance indicators. We have them for all of the different working groups in our NICU. And it shows some of the golden hour indicators, but also shows survival and line insertion and different aspects to tiny baby care, and is very helpful to review the different gestational ages. One of the things that we brought in quite early in the program, probably around the time that we were really embedding our golden hour protocol, was an email that's sent out to everybody that attends a tiny baby or an extreme preterm birth, so any baby less than 30 weeks gestation. And it gives, when you attend one of those births, we have to fill out an audit form, and this audit form forms part of our key performance indicators. We feedback with an email, and it's intended to be a positive, a collaborative email. We seek feedback, we seek areas for quality improvement, and it has been with these emails that we've actually built a real attention to detail, a timeliness for interventions, and a good area for nursing staff, particularly to feedback with ideas for changes and improvements. We often will receive emails that fill in the gaps, that tell us what worked, what didn't work within that particular birth, and give us some ideas for future changes. In last year, and this needs a new update this year, we started a new initiative with a tiny baby newsletter where we celebrate the progress of care for babies born less than 24 weeks within our NICU. It's intended to inform our staff, all staff, obstetric, medical and nursing staff, about where we're up to with our tiny babies since 2021. But I think the thing that improved or that helped with our teamwork and our collaboration was the fact that we shared stories within that newsletter. So we shared on the left-hand side of the screen Lupe, who was a Colombian baby whose parents were here on working holiday visas in Australia. Her mother had an IUD in place, but got pregnant and then ruptured her membranes and advocated for care at 22 weeks. And she had an excellent outcome. And Millie, who was a 23-week estimated because her mother did not know that she was pregnant, gestation infant who was probably more likely to be a 22-week infant who had a perforated neck, but who also survived and did extremely well. And so we shared that Lupe traveled around the world and got to meet her Colombian family and went to Italy and Greece along the way, and that Millie had recently welcomed a baby sister. So the take-home messages from my presentation are: raise expectations within your NICU, seek mentorship, collaborate widely, know your own NICU and what's going to work there. Be meticulous, be realistic, develop a local expertise, support your team, and celebrate your successes. This is Thomas when he was 5, and I'm waiting for an updated photo from him, but I guess he's in his 20s and probably doesn't want to share that now. And these are just some pictures of our little Guadalupe from Colombia, who made the paper here in Melbourne when she was discharged. And finally, just keep a positive attitude. Find your focus for tiny baby care, just like these girls. Thank you.
Great. Thanks, Dr. Walsh, for that excellent presentation. I'll turn it over to Dr. Healy next for our second talk.
Thank you so much. Thanks, Dr. Walsh. So I will now touch base on a little bit of detail about our program that we started here at the Beth Israel Deaconess Medical Center. Before I get started, I've always thought if I ever had the honor to present to this group, I would take a chance to thank this group of mentors I had at the University of Iowa. Dr. Bell, Dr. Daigle, Dr. Klein, Dr. Murray, and Dr. Seeger. They are all known for their tremendous contributions in the field of neonatology. But what they might be a little less well known for is their remarkable degree of mentorship in this area. I was lucky to cross paths with all of them while I was just a medical student, and they brought me on with projects and let me shadow them during rounds, and for years have kept in touch by email. So they deserve a lot more recognition than I can give right now, and for much more important things. But I at least have to thank them for the immeasurable contribution they've had in supporting my interest in this area of neonatology, which is really shaping a lot of my work and career now. I also must thank this huge list of people who work on our Tiny Baby initiative now. This list includes all of the clinical roles, including nurse leadership, our social workers, patient family members, and we could not do this work without all of their efforts and commitment. Now, as I begin to talk about our program, please keep in mind this is just one way of doing things. I hope that some of this is applicable to others, but certainly not all of it will be. And the efforts that I describe here started just about 3 years ago. So I can't say that this is yet a successful endeavor, but I do hope that it will be helpful for others to hear. When we put out this paper that Dr. Walsh had mentioned for our program, it was akin to publishing the protocol of a trial. We were very much in the starting phases of this. And my goal is not to recount this paper, but to illustrate that we started by asking, how could we deal with all of these new and unique considerations and integrate them into our NICU? I think what we called then Know Thy NICU, or the appreciation of the system that you are working in, is really critical in doing this. And that's what I'll spend most of my time talking about. So this is where we are in Boston, Massachusetts, in the United States, in a patch of area that's a little bit less than 1/2 square mile or 1 square kilometer, called the Longwood Medical Area. We are in an adult birth hospital, which is tucked right in here by this pink arrow. And my point in showing this is that geographical expansion, changing our landscape, is probably not likely to happen or work. But while most of the pediatric services, the only pediatric services at our hospital are newborn medicine, we are across the street from Boston Children's Hospital, which is in this area. And that is where all of our subspecialists come from. and where our babies go if they require surgical intervention. We are also part of a referral network. Each site labeled here on this map is another level 1 or level 2 special care nursery from which pregnant patients and babies may come and may eventually go back to. So this is what this looks like. Pregnant people and newborns requiring intensive care could circulate all around this system. Of course, for ELBW infants, we limit transportation as much as possible, and we certainly prefer to transport the parent while pregnant. I mentioned our spatial constraints. This is what it looks like in our NICU. I took these pictures last week. This is the hallway. We are usually 2 to a room, although for a very tiny baby, we would start them off in a single room, and then likely they would get a roommate later on. We are a 62-bed unit with between 30 to 40 patients on our acute team at a time. That team is staffed by 2 physicians, neonatologists, 2 to 3 APPs or associate practice practitioners. We have 2 to 4 RTs and a dietitian and pharmacist that will round with us almost every day. Our nursing ratio is 1 to 1 to 1 to 3, depending on the acuity of the patient. And in extremely acute cases, we may even staff at 2 to 1 for a day or so. We would start a baby born at 22 or 23 weeks at 1 to 1. We have never had a written policy or guideline stating a gestational age lower limit for resuscitation, and some in our unit would recall involvement with infants born at 22 weeks prior to this, but our data suggests that we began more commonly providing active treatment at 22 weeks in 2020. And we had provided active treatment for some infants born at 23 weeks every year, at least back to around 2010, if not closer to 2000, but we did not have a focused approach yet. So looking back since 2019, we are now seeing about 2 to 4 live births at 22 weeks and 3 to 5 at 23 weeks each year. And during this time since 2019, active survival with active treatment for this group is 50%. So going back to the start of this effort, for some time we've been talking this over within our group, and I sought in particular some advice from our leadership, but really in May 2023, we decided to get organized and we held some kickoff meetings. We did not have mini data at the time. We were able to get quite a bit by using the Vermont Oxford Network, or VON. I expect most listening know this, but when you're in the Nightingale system and you see the data broken up by gestational age week, if you extract that data, you could see the numerators and denominators for each gestational age. And so we started there and observed, for example, that while we were reporting 30% survival, if we had excluded our early deaths, it was 50%, and 1 in 5 of those babies had passed away in the delivery room and not been admitted to the NICU, suggesting they may have not received active treatment. So after reviewing our data, we had 2 early goals for our group. We started out first with an educational objective. We wanted to help our group to digest and incorporate some of the new knowledge about caring for this population that was out there. And we also wanted to develop some guidelines to more formally implement practice change. This is one of the questions that was asked by some of those registering for the webinar. So I've included the list of sources that we came up with originally. I think this is still pretty accurate, but if you know of others, please put them in the Q&A to share. First, of course, was primary and secondary literature review. We leaned on the information from the Tiny Baby Collaborative. We identified any conferences that we could attend. The certification for nursing has a special program for care of the ELBW infant that we looked into. Engage, Grow, Thrive is an online program that also focuses on ELBW care. And of course, we also sought to review guidelines and practices of other hospitals. So we also needed basically to get everyone on our team on board with this. In July of that year, we held an ethics grand rounds, which is a function of our nursing department, but included multiple disciplines and our MFM colleagues. We invited Mark Mercurio, who's a neonatal ethicist, to speak. In addition to his talk, we spent some time going through some specific scenarios that we had faced applying the lens he had just presented, and that was really helpful for us. We identified then one key area for our group to start with, and that was skincare. We tasked a group to review the educational materials that they could find in this area and propose practice changes and some unit-wide education. We chose this, and I think this was probably one of our best decisions for a couple of reasons. One of the very challenging cases we had had at that time did involve a baby with significant skin injury, and so there was certainly a sense of urgency on this. And also, this is a nursing-led area, and so this really distributed a lot of the work to that specialty. And everyone, every neonatologist knows if you really want something to get done, you ask the nurse to do it. So we did have very strong nursing leadership in this area, and so we announced to our group that this was going to be the first focus of the committee. This is also at the time that we began sharing information about the Tiny Baby Collaborative webinars, and sometimes we would try to watch those together or have discussions following them. In August, we then presented a formal committee charter to our department. In doing so, though, we really needed to define the population of infants that we were talking about and that we thought our NICU needed to focus on. We know that there were important differences about infants born at 22 and 23 weeks, but we also encounter a significant volume of babies with severe growth restriction or born less than the third percentile. So at 24 to 28 weeks, who are around 400 to 500 grams as well. And we are also seeing more and more infants impacted by earlier PPROM, which takes place around like 18 to 19 weeks sometimes. And certainly the counseling and sometimes the medical care of that group is similar as well. So in creating our committee, we acknowledged that we would address care of infants born less than 24 weeks, but also older gestational age infants as was relevant. We sought, as was mentioned, to develop and implement both education and practice change. And of course, we also wanted to be a forum where staff could bring issues that they encountered when taking care of this population. The most formidable part of this task was how to take each of these clinical considerations that was mentioned and integrate them into the existing practice of our NICU without entirely overwhelming everyone and creating confusion and leading to burnout. For those from my site listening in, I'll admit we may not have fully avoided that, but this is how I think about our committee. We have existing committees, each led by those with expertise in that area, on nutrition, on respiratory care, development, and so on. The Tiny Baby Committee is meant really to intersect with these, like the tentacles of a little octopus, and work with each group on the elements of care specific to that population. This is, of course, an AI-generated image. I was happy that it had 8 legs, but it does have this kind of unsettling glove down here. Over the coming months, Matt Rasavi spoke at a local conference to us, and so we used that opportunity to ask him to come and speak to our group also. He came around our NICU with us, and a very cool part of this was that we kind of sat down with several disciplines from our NICU with him and had sort of a focus group talk. I thought it was really helpful to bring in someone with outside perspective. We were able to really identify some of the big picture things through that conversation. Certainly his knowledge in particular is exceptional, but I think this could actually be useful even on a more local level between collaborating NICUs or something along that line. This is also when the Tiny Baby Collaborative met at PAS in 2024, and seeing that was further motivating to the group, and we were able to bring back information to everyone in our hospital. One of the things that we started after this was an ongoing case review. This is one of the ways that we can learn from every baby. When we have a tiny baby, we aim to do some sort of review in real time during the first days or week of life, if possible. Sometimes the group reviews and can actually contribute to some of the considerations about care, but we can always at least identify things to learn and things that have gone well. In the fall, we began to participate formally in the mini project, and so we have now gathered retrospective data. And we also had a couple of events pertaining to nurse education specifically. We included a lecture on our program for new nursing orientation, and we also introduced a tiny baby topic into our nursing skills day, which is a practice that takes place 4 times a year in which all nurses participate. Questions about nursing staffing and education were very common when preparing for this, so this seemed like the best part of the talk to just mention this. We're still working on a lot of it. We vary in the numbers of tiny babies that we see at one time. So we don't have enough babies to have nurses who only ever do this and don't do anything else. And likewise, it would be difficult to staff such that there is always one number of a small group of people available to admit the next baby that comes. We do ensure that nurses with a certain amount of experience are caring for these babies, and we always have a very experienced group of resource or charge nurses and a triage nurse who can support the team caring for these babies. We are exploring if we could have them located in one part of the unit. But then we run into issues of having some of the most experienced staff members separated from some of the younger staff members and not available for some of the teaching that takes place. So for now, we have this approach of sort of graduated acuity. We make sure that everyone gets support with small babies born before 22 and 23 weeks. And we think of those that are on our Tiny Baby Collaborative as super users who are available to support and educate in real time whenever they're in the unit. As I've just alluded to, we have several team members who've really taken this on. By this time in October 2024, we were pretty busy making plans, and we were pretty sure of most of the significant clinical changes that we needed to make. But before doing so, we organized this team of 11 people from all different disciplines, and our department invested in sending us to Iowa for a site visit. This group really soaked in the information and made sure to get a lot out of this visit. And further taking this was a nice way to recognize the work of the people that had already put a lot of effort into this. Once we came back between that visit and our earlier work, we had a huge list of change ideas. We held a session to evaluate them and try to determine what we predicted to be the level of impact and difficulty in putting them each in place. And you can see here just an example of what this looked like. But shown here, we identified 3 high priority change areas that we then presented to our department as our goals for the coming year or so. And then we had to really get to work making the details of these things happen. Also, none of this happens at all in a vacuum. There's a lot of other improvement work going on in our NICU. Notably, we are participating in the Bonn iNICU All Care's Brain Care Project that's led at our hospital by Dr. Emily Weitzel. And within this, we've been focusing on both developmental care and golden hour care. So we included at this time golden hour work for tiny babies, and we launched a focus on developmental care and positioning for this group. In March 2024, we started using high-frequency jet ventilation in our unit, the implementation of which could be a talk all of its own. We also put out a new PDA treatment guideline, again, work that has been done separately, but with a lot of overlap to this group. And our nutrition team did just a tremendous amount of work on multiple guidelines, including TPN use, IV fluids, and management of hyperglycemia. In September to November last year, we did our first own review of our data. We extracted the data that we had entered into Mini, and we did a deep dive to review it and presented it and discussed it with both NICU and MFM seminars. We did introduce also at that time use of more hypotonic IV fluids, and we were able to expand our access to point of care electrolyte testing. So those were the 3 high yield areas we'd identified. So thinking back to that little octopus who's now hiding 2 of her legs, none of this happened in isolation. We intersected with other groups and other projects to do all of this work, which allowed us really to leverage the expertise of our staff and made it such that work motivated by the goal to standardize and improve care for infants born at 22 to 23 weeks could also have benefits well beyond that population to other infants in our NICU. This table I will not go into in detail. You're welcome to save, or I can share, is a summary of the changes that we have made in each of these areas so far. And I find it helpful to maintain something brief like this that I can present to our group and remind us of some of the work that we've accomplished. Also, I'd like to just re-emphasize the role of data in this work. We've used data to inform these processes, which has come from Bonn and Mini. We have also collected much of our own data to follow process measures. And we are exploring also collaborating with some data collection with others in our region. This table as well, I will not go into in detail, but I'm happy to share. This is a list of our measures for internal use. Some of this comes from Mini, but much of this requires data collection directly from the chart. And we're doing this to see if we are achieving some of the improvements we had set out to make with the specific changes we've made. For example, we look to see if patients may now require less volume and blood transfusions related to the change to implement more point of care testing, or we look to see if infants who might need less insulin after we've changed to lower concentrations of dextrose being available. And at this time, now in the spring of 2026, we tried to shift our mental model a little bit away from continuing to make major clinical changes and instead are allowing the unit some time to acclimate to the changes done and gain some comfort with them, while simultaneously working, again, overlapping a lot with other projects in the NICU to improve on a sense of continuity within provider roles and work on our communication and consistency for families. One thing we've started to think about is somehow formalizing the role of a consult or support team to help both families and providers. That's really just an idea that's starting to take shape now. And as I mentioned, we've thought about how to best use our physical space, but have not made final decisions about that. In summary, I would recommend investing in some time to understand your steady state and planning, to partner with champions in multiple disciplines, prioritize the big changes you'd like to make, to collect and use data, and to capitalize on areas of strength and existing culture. And finally, as Dr. Walsh said as well, it's critical to involve families in all of this, and only they can give us the most important feedback. We are very lucky to have many family members who take time to come visit us and send updates. Sophia here just happened to be in our office last week, and her mom said I could share. So here she is, before I wrap up, just literally barging in to give Dr. Zupanzik some feedback. So with that, I'll close. Thank you all. We're happy to take questions.
Thank you so much, Jennifer and Helen, for two very inspiring talks. Thank you for sharing your experience. I always learn from you. One thing that while we're waiting for more questions in the Q&A from the attendees, I think one of the common topic one of the many things you talked about is teamwork and collaboration. And which I love, Helen, your octopus, like you have to work with different work groups but one of the struggles, for example, that we face is how to sustain this continuous change. And you mentioned, Helen, like we had to slow down a little bit. There are always so many things that are happening and changing. So how do you keep this and how do you sustain this culture of change in a very complex system like the NICU, where there are conflicting priorities sometimes?
You go first, Jen.
How do we sustain the culture of change? I think it's really keeping connected with everybody. And I think that our emails really keep it current for every baby and reminding people the importance of every baby, not just the data at a group level, that every baby is important. And that the culture really it changed to include our obstetric team members more. That was something that probably we worked in more silos before this, I feel, and it's really actually helped us to really understand their perspectives around, for example, cesarean sections in babies at 22 and 23 weeks, and they understand our perspectives now. And I think that's really sustained that discussion and that dialogue and that presenting those kind of details at different seminars, webinars, mortality reviews has really sustained the discussion and the constant thought about it.
Yeah, I agree. I think the individual stories are probably the most motivating to continue on. One of the things I like to do whenever a tiny baby is admitted is try to go to the bedside and talk to the nurse within the first day or so. And I really noticed some changes I can't really measure in that. But the last time I did this, one of our nurses, I think I had to probably spend about 30 minutes talking to her about why the baby hadn't gotten a complete course of steroids. And she was just, really, really motivated to why did that happen and what could we do differently in the future. And I think she's taking care of that baby now, over 100 days. So those are the kind of changes that I think really keep this going.
All right, so I'll go next. Thank you. Thanks to both of you for very informative presentations. And I have a question, and many people ask me, is there a minimal volume in terms of how many babies you care for each year? I mean, the numbers are small even in large units, and these cases quickly get diluted, so to speak, in terms of number of babies per neonatologist, per nurse, and so forth. So, I mean, I guess the question could be phrased along the lines of, should every NICU have a small baby program? Wonder if you have any thoughts about that, or if you are having ongoing discussions within your setting or your network, if care should be centralized in some way.
Yeah, I mean, this certainly comes up quite a bit, and I know that yeah, I certainly don't have the answer to that. In our healthcare setting, it's would be probably a very long time before we have any sort of centralization. We do try to work with the NICUs around us so that we can all learn from the population of babies that are in our area, and I think that that's really a critical next step, and potentially gives opportunity to learn from each other, you know, maybe even more so. The other thing is that even while it's a small number of babies, as we know, they're in the NICU a very long time, and we can look for opportunities to measure what we consider process measures to look for improvement and means, for example, you know, looking at how the baby is positioned every day can give you, you know, 150 measures of on one baby and multiple different, you know, care teams and assessments. But I don't know the absolute number, but if someone does, I'd love to know.
Yeah, I don't know that we know the number either, Johan. I think it's really interesting to hear how Japan do it, and they have so many centers with so many small numbers, and they do exceptionally well. Um, Part of our group feels that, you know, there's periods of you know, tumbleweed where we don't have 22 and 23 week infants, and we want to continue the kind of progress of having babies through, and so more numbers would be better because we feel we'd have the ability to get our teeth into it a little bit more and a little bit more practice. But I don't think that we know the answer to that. We looking at our numbers of 12 babies at 22 weeks in 5 years is not very many, with some years having no babies at all. So, you know, there is an argument for centralization, but how do you do that? And that's tricky. In Victoria, we have really 3, 4 perinatal centres, and some of the other states in Australia have far more and have far fewer numbers, so they have more to contend with. We at least have a decent number of extremely preterm babies, and are 120 per year in our unit. We feel that we have the capacity to learn and to build on our expertise, I guess.
I mean, I guess one follow-up question would be, I guess you started quite recently, but is there sort of, as time passes and you get more familiar with this type of care, has that influenced the proportion of families opting for active treatment, or do you see any sort of things going in a direction?
I'm happy to take that one to start. Is that all right, Helen? When we started I guess in the state of Victoria, there was a few centres who had different attitudes. So one of our centres decided that 22 weeks was now a change in the line in the sand for resuscitation, and so that really it was all care if families wanted it. Whereas in our centre, we decided to be quite restrictive when we started. We wanted those babies at 22 weeks to have full steroids, to be in the most optimal condition that we could have them in, and we recommended palliative care to babies, to women who were pregnant with babies at 22 weeks and who were having those babies at 22 weeks. And we still have that as our overall recommendation, but there's definitely been a cultural shift. We're much more, because of the success, I guess, we've had more than 50% survival. And when you have success, you realize that if you don't provide care, you've got 100% mortality rate. And if you do provide care, you have more than 50% success rate, then you may have the ability to work with families. And particularly at 23 weeks, we've had a lot more babies born not provided with, having not had steroids, for example, where we provide care to those babies, and not without problems, because there has been a significantly increased IVH rate in those babies, for example. So when you kind of look at 22 and 23 weeks, you can't really cut down the middle and say you are now 22, you are now 23. It's really that individual baby and that working with the family. We've gotten it into situations where at 21 and 6, even though we will not provide care at 21 weeks, a woman refused to allow herself to have her baby at 21 weeks because we wouldn't provide care, and that was to her own health detriment. So our team decided, well, we have to work with this family, and so we did accept that we would provide care at 21 and 6 if she birthed then. She actually birthed at 22 weeks in the end. So yes, things change, things shift, and we've definitely shifted our attitude at 22 weeks because we've had success.
I want to switch gear a little bit. So there are a lot of questions in the Q&A about education. I think you both touched on that. But there are a lot of questions on how can you educate like a large number of nurses? There's so many things to work on. Do you include tiny baby care in nursing orientation? If you can speak to that a little bit. And I can also share our experience.
Yeah, why don't you go ahead, Thea?
Oh, okay. So definitely what we found, it was hard to share the specific education for all the nurses. I think we have 200 and plus nurses. So the way we decided to approach this, we do twice a year nursing skills where we touch base a little bit on the golden hour, like basic, on admission and positioning. And then we do have a dedicated educational meetings twice a year, and that is dedicated only, it's for the nurses that are interested specifically for the care of tiny babies. And we're lucky enough that our nursing leadership allocated some fundings for that. And then we do twice a year simulation workshop specifically for the nurses that are interested in this population. And we focus on areas that are priorities for us. Like this year has been the golden hour and the living room experience for those babies. So I think you have to have some support from leadership, both from a physician standpoint and the nursing leadership to have some resources allocated for this effort.
Yeah, I agree. Yeah, at the University of Iowa, I feel like that's one of the big things that we talk about is having a smaller area with only certain nurses that care for this population. I kind of liken it, most people are like, yeah, not every NICU nurse is going to take on the ECMO baby or, the hemodialysis baby. This is very similar with those sickest kids that, it takes a little bit more training and experience and expertise in just getting comfortable and knowing the patient population. And it does have a really big impact to have that, but you do have to grow it, and it can be hard to schedule that and distribute that evenly across shifts.
I think we're continuing to explore and figure that out. We could probably have a whole other discussion with nursing leaders on this to probably answer this question much better than I can. But we have similarly probably around 200 nurses, and we have a lot of people that are early in their career and are training. We have a group that's probably sort of self-selected in a way as being highly interested and really taking on extra learning in this group. And then often they become the coaches and mentors for others. We try to pair a lot with training. But I think when we didn't have, if and when we haven't had that, and a nurse has not felt adequately supported to take care of a baby, that became very clearly something that we needed to change next time. And the team has really requested that, and our leadership has really provided a lot of support to make that possible. But we're always learning.
Yeah, and I think it's good to keep it all multidisciplinary, from making the guidelines and developing it to even when we have people come visit for our tiny baby program or go elsewhere, like we try and make it be like a multidisciplinary team, because that's what you need. But then people also have more buy-in for it when they're a part of it and they're helping to follow the data.
Yeah, I agree. Also for us, we have a steering committee where every discipline is represented. We meet once a month and we discuss priorities and look at what are the issues, what we need to address. And that's also many times it really leads to the next guideline, right? Like what is the priority in the unit, right? And as much as a lot of the time, of course, there's a lot of QI going on, but it's also patient related. What is issues? What is that we see in our unit that we need to address? And usually that's how we create the next, for example, guideline or protocol based on the needs of the unit. One thing that going back to the nursing education, one thing that, for example, we discussed was like, should only the most experienced nurses take care of these babies? And one thing that we realized is, of course, it was really helpful to have the most experience, but also maybe someone that is very engaged, and even younger nurses that really have high interest in this population. We were successful in engaging them and giving them the opportunity to take care of these babies. And I think that also led to having more people signing up for the program and more nurses. It's a lot of work. It's not for everyone, taking care of these babies, and also for adherence to our own guidelines.
Should we
go ahead?
Oh, I was going to say we have gotten some questions not into the Q&A that I wanted to touch on, and one was about the safety data for low dextrose infusions or using really hypotonic infusions. I know that's a big practice here at Iowa. Do you guys use hypotonic infusions? Do you put them through just your UAC, or what is the way that you balance fluid management for these kids? I can speak to it too, but just wanted to see your perspectives.
We're still feeling that one out. That's why we did the tiny baby sodium audit, and we're hoping that will inform a guideline for us. So it's very case by case for us, Brady, at the moment. We're looking at the baby and what they're actually needing. And we haven't kind of evolved into what way we give the fluid, where we give the fluid formally as yet. And I think that will be work that will probably happen in the next year or so.
Yeah, it's we've recently gone through that adjustment, and it definitely took quite a lot of kind of discussion and investigation. We found a lot of the practices of other units really helpful in kind of offering us some confidence in what we were doing, and also in looking at the Tiny Baby Collaborative webinars. There was one that was had, so we sort of knew this one was coming around this topic of insulin and GIRs and things like that. And so we said, okay, like this is going to be our decision point. We're going to all sit here and listen to this, and then we're going to talk about it and decide. And we found that pretty helpful. We sort of went back and forth a little bit, but we ended up, at least for our group, feeling more comfortable that we were confident in using insulin without having many of the side effects, but that we, really could make changes that would allow us to stay at a GIR, even a 4. A lot of the times before we were making those changes, we were not able even to be that low. So we rarely do go below that. And then as far as where to put them and things like that, Dr. Klein's computation on the wall of a cardiac output that none of us have quite been able to replicate verbatim, but that helped. But we do still face some nervousness about those things. But we also had incredibly high glucoses and sodium levels that we saw harms from.
Yeah, so go ahead.
Right. You can share your experience, because I think we are all learning from your team.
Yeah, I'm just going to jump in because yes, you mentioned, John Klein. We are much more comfortable if you're putting the more hypotonic fluid through a UAC. We use high UAC, so it's mixing directly into your cardiac output. So it's going to be kind of diluted down quickly is the theory that we go with. But we usually actually, one of the ways we teach it is we use like a 3-bag system almost. And our fluid management also is very different from a lot of other places, because we're those wild people that don't use humidified isolates. But even, as you get lower and lower, I imagine even if you are using humidity and an isolate, the kidneys themselves are so immature, especially getting down to like the 21 weekers, that I think anyone would have lots of electrolyte changes and problems. But so we'll have our, kind of concentrated NVN fluid running through the UVC, and then we run sodium acetate through our UAC, and sometimes that is relatively hypotonic, but we're okay with that. And then we can add an IV piggyback to the NVN itself. And that's one of the big ways we give a lot more free water, is with everything that you have placed into your NVN, you're then just mixing it in, diluting it down with a lot of free water, but you're not just running that solely into your, UVC. And it gives you a lot more room for titration there, and like concentrating the NVN down to just like a part of the total fluids you anticipate you need means you're always going to hopefully be able to give like the protein that's so important to be able to give as well. And then checking really frequently in labs, we are getting labs every few hours for these kiddos for like the first week of life, and making adjustments based on trends. So just because something, is still in the normal range, if it went from 135 to 142 in 3 hours, you still want to be making changes or you're going to lose control. And then always saying, you have to think about the rate at which your fluids are running too. It's often really low in these babies. And so people will say they want to go up by like 20 mLs per kilo per day. But, if you're just increasing your drip rate by like 0.3, 0.4, 0.5, the baby's not really going to see that extra free water to meet their deficit very quickly. So oftentimes you have to make larger changes. But we have used on hundreds of kids, like, the relatively hypotonic fluids through a UAC, and then had good luck with just running via IV piggyback mixed in with the NVN to help with giving a lot of free water to these kids, because they need a lot.
I think also when encountering like some of these tricky situations, this is where the connections made through the network have been really helpful as well. I've sent more than one email to Johan about a sodium, and others as well. Just making, sometimes you just want to know that you haven't missed something, or that there isn't a better answer, and that can be really helpful and provide some comfort.
I do want to change again a little bit, shifting the gears, and there is a question about how do we involve family in the small baby program or the tiny baby program? how family partners were identified and what were they involved in and how did they contribute to the guidelines development for the units. I think this is really important to address the family involvement in this in the care of these babies, if you want to speak to that.
Sure, yeah, we're really fortunate that our nursing department has invested in having a family programs manager and a former family NICU parent who helps sort of bring families into that work. So I started there reaching out to families. Of course, we all remembered many families that were sort of top of mind that we thought would enjoy doing that. And some have gotten, very involved and some are on a mailing list and will come in from time to time, but they're all, give really great insight. But a lot of times it's kind of apparent when they're in the NICU and you get to know them that's something that they would like to do. I always struggle a little bit with when there is the kind of the right time to make that ask. And so that's where often I'm talking to either one of their primary nurses who knows them really well, or our family leaders can be helpful in kind of identifying how to sensitively ask that.
We have implemented FICARE in our NICU, so we are very focused on supporting families to care for their babies, and I think that our nursing team would have thought that we were a family-centered care institute before we implemented FICARE, but I think that FICARE has actually improved the attention to detail and including families in all of the cares and aspects of care for their babies. We have a mother of a 22-week gestation infant who's just recently turned 1 on our working group. And she's been really, really good at actually talking to the emotional aspects of care and making me think a little bit about how we might look at that, study that. And I think that's been the most helpful part about having her on the working group, asking the questions from a parent's perspective.
Yeah, also for us, it was key to have a representative part of the steering committee and have that voice represented in our discussions. And actually, I mentioned we have meetings twice a year, and in those meetings, once a year, we invite families to share their experience. And thanks to the feedback of one of the family, we were able to cohort the babies. It was a struggle for us before because from a nursing perspective and from us, like nursing assignments was hard to cohort this baby. We are open bay type of unit. But thanks to the feedback that we heard from one of the parents, we were able to really have that push through. Basically, this mom shared how hard it was to she had a baby at 24 weeks, and she shared how hard it was to be right next to a full-term baby that was going home in 48 hours. And so that was probably more powerful than maybe the leadership from the physician standpoint to really push that change to happen. And so just to say that having that voice is absolutely important and to have so that because you can see things from a different perspective, needs that we might not see.
I could add from our experience. So we sort of what Jennifer alluded to, that learn from every baby. We try to learn from every family, and we have families present and taking part in all kinds of cares right from the delivery room. So by having them with their baby at all times, with the staff, they guide us through the whole journey. It's not like we call them in when they get older. we try and learn from every family that we have in the NICU, and I think it has been quite successful. But I almost laughed when you said that we thought we were family friendly, or that
Centered.
yeah, we were not. So, but I think we are getting closer to being integrating families in care now, and we learn so much from day to day from the families in real time, so to speak, since they basically live in the NICU with us.
All right. Well, thank you so much. I think we'll go ahead and wrap up, but I'd like to just thank our speakers and moderators for sharing their expertise. And thanks to everyone who attended. I hope you found it valuable to improve tiny baby care in your centers, and we hope to see you again at future webinars. So thank you.